So like Kevin alluded to, the call today or the webinar today is really focused on medical direction, and we're approaching it from a bit more of a zoomed out approach of an overview as opposed to getting really into the weeds and answering really nuanced questions. So really this is just to kind of go over things that ODYSSEY does, things that are more applicable to the field of medical direction and are a bit more general with this. So I spoke a couple months ago, and it's great to see a lot of familiar faces who I've been on an event with and who have tuned into the last couple of webinars. So thank you so much for everyone for jumping in. So my name is Haddon. I'm a registered nurse based out of Vancouver, and I support the medical direction program with ODYSSEY. I don't have any disclosures, and the general medical direction team took a look at this presentation, and I just want to say thank you to Dr. Brendan Munn and Dr. Jill Colby for taking a look recently as well. So like our previous webinars, this will be broken up into two parts. So a talking part and then a discussion part. Hopefully it won't be quite 45 minutes, but we'll see. So really the big takeaways that we want to focus on for the actual talking part is that your individual scope plays a really, really huge role in medical direction. That's a central pillar to medical direction and what you can and can't do. The second bit is that there are two main models of medical direction. So you have online, so real-time medical direction, and you have offline, so pre-written and delayed medical direction to a degree. And the last takeaway is that medical direction is very organizational and medical director specific. So there's not a blanket approach. There isn't one set model that every medical director would use. It's very nuanced and specific to that organization. And like Kevin mentioned, this is recorded and this will be posted on our YouTube channel as well, so that you can review this at a later date if you're interested. If there's any specific questions, feel free to drop them in the chat. We'll try to answer them at the end of the call, or we'll share them with the medical direction team and get back to you about those. I'm not a medical director. I'm not a full subject matter expert on this, so I'll do my best to answer what I can, and we'll bring it back to the experts afterwards. And we just want to acknowledge the Indigenous, ancestral, and territorial lands that we live, work, and play on. Since we have folks tuning in from across the country, we really wanted to take a general approach to this. So that is, yeah, we're grateful for that. So the first thing that we're going to talk about, and again, this is what we're really focused on here, is scope. So what can you and can't you do, and how is that determined? So we're not going to get into the weeds. We're going to keep this kind of big picture, and we're going to outline kind of the four main pieces that come together for scope. So the first bit, which influences your scope, is legislation, right? So what are the provincial and national practice guidelines and acts that enforce what you are really able to do within your scope? So this could be things like the Nursing Act. It could be an Emergency Health Service Act, the Ambulance Act, all these different things that come together to shape what you are able to do in your scope of practice. The next piece is the college or the regulatory body that you report to. So they really help to endorse from those acts what skills or acts are you able to do in your own practice that are governed by the college or your licensing body, and how are those things actually regulated and endorsed, really? So what training are you able to do to upskill or to maintain competencies, and really outlining the licensing regulation and helping to support you being able to practice in good standing. The next aspect is the employer. So what is your employer actually supporting you to do? And this should all be outlined in whatever employer you're working for, in their organizational policies, with their medical direction team. So for ODYSSEY, the teachable modules, especially the medical direction 101, outline this aspect of what is supported. And really with the employer as well, they'll help to outline, are there any extra trainings that they endorse or that trainings that they run that they support? And so when you kind of get into a training model, the employer can really start to dig into, here are some extra skills that we can help support, and the training and sign off that comes with that. But we'll get to that in a little bit. The last bit of this is the individual provider scope. So with the legislation, the college, and the employer, that ties in really nicely to what are you able to do based on your skills, on your training, on your comfort level, knowledge base, all those aspects coming together. So medical direction really helps to support the individual provider and looks to support the scope as outlined by the legislation, college, and employer. So at the end of the day, clinicians can help work up to their full or partial scope of practice, and that's influenced by a lot of the things we just spoke about. Which brings us to the question of what is medical direction? And so the actual definition is the advice, guidance, orders, or direction from a clinician who has an autonomous medical license given to staff with restrictions on their licenses or certifications. And again, this stuff is all very organizational and medical director specific. So it's not a blanket approach. And with medical direction, some things that can happen is that the structure can be provided to help clinicians work up to their scope of practice, support restricted activities, things that can include the administration of advanced medication or delegated medical acts. And when we look at medical direction and its applicability in the field and the actual operational aspect of it, we can see it in a lot of areas, right? We see it in hospitals, we see it in pre-hospital services, and we can get even more granular, like industrial services, single events where it's an in-house service. It's the medical director providing that medical direction for their smaller team, and for whatever way that medical direction is being applied, it's always a little bit different and nuanced to the organization and the environment which it's being applied for. So we'll start to dig into some of the considerations around medical direction and some of the different operating models and factors that can influence what folks are able to do. So the two main types of medical direction are online or direct medical direction and offline or indirect medical direction. So online medical direction is really focused on providing real-time medical guidance to the team, which can be done through on-site support or through telemedicine capabilities. So there's still an element of pre-written protocols, but if you've worked for a paramedic service, you've probably seen and read through the policies where it says, do this, do this, do this. If that doesn't work, call the base hospital and get some medical direction. So we can see that there are pre-written policies, but there's still that element of being able to connect to a real-time clinical decision maker to help with some of those guidances and offer support. On the other side, we have offline or indirect medical direction, which is focused on pre-written protocols, orders, policies, and having them set up in a way that they can be accessed and used without having real-time clinical decision maker availability. One of the other considerations about online medical direction is that you really need to be focused on those medical directors or those providers having an intimate knowledge of the local healthcare system. So what can the local pre-hospital system do? What resources are available? What form of reliable communication can you use? So if you're providing online medical direction up north, do you have a satellite phone? Do you have reliable internet access? What are some of the considerations that are needed there? So there are some differences between the two models, and depending on the events and whatnot, you may see one model or the other being used. And then the two main types of scope endorsements and areas that we support, or the medical direction supports, is BLS and ALS. So with BLS, it's really kind of focused around BLS interventions and symptom relief. And often it will incorporate reputable and well-established treatment protocols from things like places like BCHS, Alberta Health Services, and incorporating those protocols or basing other protocols off of those established and well-made protocols. On the ALS side, that's where things can start to get a little bit more where some additional considerations will start to come in about what ALS interventions are being endorsed or what areas are being supported, and really taking a harder look at where the risk tolerance is around, what medications are being used, what interventions are being endorsed, and how can those medications and interventions support the team, and then what's the communication and support system from the medical director or clinician who is supporting that. ALS is harder to do without online medical direction because, as you guys may have seen from different protocols and whatnot in the ALS area, it is, you have more complex patients and you have higher risks associated. So when you're administering medication and you're providing interventions, oftentimes in those ALS protocols, you'll see that once you get to a certain step that you need to call in for some additional support from a medical director or from an online clinician. The other thing to note, and I kind of talked about this before a little bit, but in terms of scope of practice, there are some companies, some organizations that do in-house training and supporting the certification and scope enhancement. So this is not a blanket approach. It's not for every organization, but there are some that will provide training that can help support the expansion of scope through in-house training or other recognized forms of training, and that is very organization specific. And so from there, we can start to think a bit more about where some of the documents that come in to support medical direction. So there's three main ones. So you have your protocols or your policies around guiding the clinicians through the exact medical plan or algorithm that follow that condition. And then you have guidelines, which is a more general approach to learning, education, and some other potential pathways that can be considered when supporting patients who have a certain condition. And then you have orders. So you have real-time orders, which can either be given in person or over the phone, or you can have pre-authorized orders. So similar to, nurse-initiated orders or paramedic-initiated orders. And those are orders that can be actioned without that prescriber being physically present, or having that outline criteria around when you can give certain medications and when. Again, very organization specific. This isn't the way that every team or every organization will approach it. And then when we start to think about medications, this is also where medical direction is really helpful to have. So these are the main categories of medication, the different schedules. And so with Scheduled 1, so prescriptions, and Schedule 1A, controlled medication, which is also prescription-based, this is sort of where medical direction can really step in and start to support in the sense of what medications is that team or organization going to use, what does that formulary look like, and how can that medical director or that team support the management of those medications. And this is especially applicable for controlled medications if that medical director is comfortable supporting the provision of controlled meds, because there's a lot of preparation, management, and considerations when you have some of those higher risk medications on site. I'm not really going to talk about equipment a whole lot because there isn't a lot of equipment that actually requires medical direction. That's much more encompassed in scope, and a lot of equipment doesn't require medical direction. There's only a few that actually explicitly state it. So the real focus here is medication, where medical direction can help with the prescribing, the management, and the oversight of those drugs. And then when we start to think about quality assurance and oversight, some of the considerations are here. So how often are policies being reviewed? Are policies or the comfort of that medical director, are they basing it off of other established policies which are being updated frequently and have other QA mechanisms involved? Is there a mechanism for PCR audits and stuff to make sure that medical direction is being followed appropriately, especially if there's some higher risk medication being given. And then also just focusing on accessibility. So how are policies or that guidance being accessed? Is there a handbook? Is there e-learning sites? Are they on a website somewhere? And then from the medical director perspective as well, there may be some considerations around ensuring some of those policies that may have been written in-house, how team members can provide feedback, and then even some considerations around documentation. So how are team members citing that they're using certain policies and using the policies as a reference point when they're doing their documentation. So there are benefits and there are risks with medical direction. Medical direction is not without risk, obviously, but starting with benefits, through medical direction, clinicians can help work up to a higher, or work up to their scope of practice, which is always terrific, because the outcomes of team members being able to work up to their scope can lead to higher quality care, can lead to optimal or better outcomes, and enhancing the operations of that team, because team members can do more and service more. And really this supports that ultimate goal of, in the event context, of mitigating the amount of patients who have to be sent to the hospital for care. So through medical direction on events, we're hoping that we're able to mitigate the impact of those events on those local communities. There are some risks associated with medical direction. So there's quite a few, but these are kind of the main ones that pop to mind. So there is an increased responsibility for clinicians that are authorizing medical direction. So they need to ensure that, the T's are crossed, the I's are dotted, and helping to ensure that everything is evidence-based and within their comfort level. Another consideration or risk really is that there may be some medical legal issues that could arise if QA isn't being followed as needed, or that policies or guidance may not be as concise or as clear as needed. And then also just risks if there are some real adverse events, and not necessarily even medical, but just operational. So for instance, like controlled medication is an example where if all the controlled medication disappeared, then that is a major problem for that medical director. And those are situations where, even though it's not necessarily patient focused, the operational outcome of that can lead to some major risks for the medical director. So really, medical direction doesn't eliminate or absolve risk. It just changes some of the risk paradigm and really helps to focus it on the aspects of clinician responsibility, that quality assurance, and the management of the medical direction resources available. And so there are some regional variances. We won't really get into this a whole lot, but just it's important to know that province to province, there isn't a lot of consistency, and there are differences in scope across all boards, the role of the medical director, and how medical direction can influence the care that's being provided. Now, as we start to tiptoe down the line, we start to think about the role of the medical director. The responsibilities really start to come to light around, what are some of the considerations that the medical director will need to do before they can actually start to provide medical direction, or that they need to do and maintain once medical direction is already in play. So being licensed in the region of service is a pretty major one. So if you're licensed in BC, that doesn't mean that you can provide medical direction in Quebec or somewhere in the Maritimes. You have to be licensed in that region to support that. So be licensed in your region of service, and then meet those regional licensing requirements. And then from there, increase the insurance on your license, updating your license so that it shows that others are working on it as well. And then really working to have a solid understanding of the scopes of practice that you're supporting in that region. And then if you're providing online medical direction, some of those other considerations are really rooted in ensuring that the prescriber-patient relationship is being made, that there's an established way to share that medical information. And then from documentation, especially if you're doing it digitally, that you're doing it in a way that complies with e-health laws in those regions. So that the personal health information of those patients are being maintained and that they are being respected and that privacy is still being abided by. And then the last little point around online medical direction is just understanding what's going on in those local healthcare systems. So understanding the region that you're servicing so that you have an idea as to where some hospitals are, the services that are being offered, the type of care that your team is able to provide, and the type of care that the local paramedic service can support as well. So, ensuring that if the local paramedic service isn't able to accept intubated patients, that you're not doing interventions that supersede what those regional resources can accommodate, because that will influence the care that you can provide and the care that can be sent over to tertiary care. So those are some of the responsibilities of the medical director, and then some of the responsibilities of the medical staff are really, again, rooted in scope. So fully understanding what you can and can't do and what's in your scope is a really major one. Taking a regular review of the policies that you're working under. So whether that's organizational policies, if that's provincial policies, hospital policies, wherever you're gathering your medical direction from, and understanding those policies to make sure there haven't been updates, that you're following best practice. Another aspect as well is ensuring that your license or your certification is that you have insurance for your practice is a big one. And then really the kind of going back to the independent scope is working within your scope of practice. And we'll go into that in a second, but that's honestly a real big one with this as well. I know it's not a shocker, but really focusing that you're not overstepping or going into the gray area really, and working within what you know as your defined boundaries based on those four considerations: legislation, college, employer, independent scope, and taking that into consideration. The very last one, and this is something that we always want to reinforce, is just around controlled medication. So if controlled medication is present, you're making sure that you're logging it carefully and that you're logging it frequently. So you're doing counts often, and if there's any discrepancies noted, that those are escalated to the appropriate individuals on site. So now we're going to just start to talk about some myths and some misconceptions that may be around medical direction. So the first is around scope. So there have been some myths or some folks who may think that your scope is automatically expanded as soon as you have medical direction, and that is false. So like we said earlier, medical direction, it doesn't expand your scope of practice unless it's been explicitly stated and there's been that discussion, there's been that training, and there's been absolutely clear language around an expansion of scope. But by and large, medical direction does not expand your scope of practice. And again, scope expansion can occur, but that's after an individual has been trained, they've been signed off, and they've gained competencies. Again, going back to risk. So the clinician has no risk when providing care. And again, this isn't necessarily true. There's always risk present, and the onus is still on the individuals to provide good care, to provide it with best practice in mind and using evidence-based policies. If there is any sort of, if there are any errors or the policies are written poorly or the guidance isn't up to standard or something, then there is responsibility on that medical director or that medical direction team. But if there's an error made providing care that is due to negligence or due to not following best practice through your own through your own decision making, then there's still risk to the individual provider there as well. So again, medical direction does not absolve you of risk. It just changes how risk is presented. And there have been some individuals who have inquired about licensing. So talking about, I'm not licensed now, I'm not certified right now, but I used to be. Can I still be covered? And unsurprisingly, the answer is no. you can't be covered under medical direction if your licenses or certifications have expired. They have to be maintained and in good standing for medical direction to apply. And this is the final myth I want to talk about is around the Good Samaritan law. So the myth around you don't need medical direction because you're covered under the Good Samaritan law. And unsurprisingly, again, that is false. We'll talk about this in a second, but in essence, the Good Samaritan law does not replace medical direction. The Good Samaritan law is really it's really focused on supporting lay responders responding to an emergency or an incident that happens without expectation or like in real time. When you are advertising yourself as a if you're advertising yourself in an official medical capacity, so think like a search and rescue team, an event medical team, an industrial medical team, when you're advertising and working in an official medical capacity, Good Samaritan law does not apply because you are really advertising and taking on an official medical position. So Good Samaritan law is rooted in protecting lay responders, but it's not focused on people who are acting in an official capacity. That is the end of the talk so far. So we're going to start to transition into the discussion. But thank you so much for joining, guys. And there will be some links I'm going to share at the end of the talk that just are focused on some ODYSSEY specific medical direction guidance. And then this talk will be uploaded to our YouTube channel as well in the next week. Thank you so much for listening, and then we'll start to jump into some discussion points. This is, I'd love to hear some of your experiences with medical direction, and we start to talk about some questions or just some general comments, and just start to have a bit of that discussion. So the first prompt that we have is just rooted in what's your experience with medical direction. So we'll be taking a look at the chat and whatnot. So if anyone has any comments, we can start to chat there. So Aaron's asked, what happens when you can't get a hold of the medical director on a call? So sorry, Aaron, are you talking a bit more about like pre-hospital paramedicine?
Yeah, pre-hospital care, or if you require a physician to sign off on discharging a patient and you can't get a hold of them by phone or any other means, then what's the best course of action?
Really, so I think if you have an online medical direction model and you can't get that, you can't reach that clinician who's able to provide that sign off or that guidance. From my understanding, it would be best to try again and wait until you have that connection with them. If they're online, then you should be able to reach them if they're busy with another call, for instance, within a short time span. So holding off on those interventions or that medication as per the policy outline, basically, and just trying to reach them again. And Daniel has written, I'm a primary care paramedic who has had to call medical direction in an industrial setting to clarify treatments. While working in industrial, I did also wonder what to do. I could not call medical direction. I never called medical direction while working on an ambulance for AHS, but have easy access to PRUs, ACPs, and other backups. What sort of programs or software would you consider to assist in online medical direction internal to ODYSSEY? Great question. So I think really if ODYSSEY is providing, so in an organization specific context, I think the big thing that we would focus on is that telesupport. If we didn't have on-site clinical decision makers, where we could essentially patch through, get a hold of someone who's able to provide orders or authorization over the phone, and reach out to them that way, as opposed to like a messaging app or something, partly around those e-health laws and the concern around patient privacy. So we wouldn't want to send the context of to explain the situation with patient identifiers over a social media app or something that's unsecured or unencrypted. So phone would be the best way to connect if we were providing off-site online medical direction in our organizational context.
Understood. I agree, because the AHS EMS app was really great for pulling up protocols, even for some situations that might be tricky. As long as you follow the pathway, you were doing great. Versus the industrial setting, where sometimes we didn't have a lot of direction, even for simple stuff like medical related nausea. So thank you for clarifying.
Yeah, oh, no problem. Anyone else have experience with medical direction that they want to share, whether it's, if it's in a remote setting or something atypical, any other experiences with it? Awesome. So we'll go to the next prompt. So just for team discussion or for thought, where do you see the future of medical direction going? I think we're seeing a lot of really interesting changes to scope of practice, and scope is it looks like it's sort of increasing for each type of provider. So people can do more and they can support more interventions and medication administrations. Just curious where everyone thinks medical direction will be heading in the next little while. Yeah, so Aaron wrote video, FaceTime, e-health. Yeah, that's a really interesting point around, especially during the pandemic. I think we've seen a real spike in accessibility for those e-health modules or e-health platforms to actually connect via video or telehealth with folks, which is really, really interesting. I think there are a few big organizations in Canada who are working to enhance that a little bit and to make it more accessible. Daniel's mentioned automation. Yeah, that's a really interesting point as well. There could be some interesting areas for automation around protocol retrieval and for guidance and to help support some of the algorithms that are out there. And who knows how that will influence it. But automation could definitely be a part of that, especially like when we start to think and look into what artificial intelligence is doing recently and the accessibility of that area. There may be some interesting overlap between being able to pull certain policies or being able to create some structure around how policies or how guidance is being given, but that may be a little bit further down the road.
Just interesting that Daniel brought up automation. I was wondering about the future of ChatGPT as a medical director. So basically, you put the symptoms in, you hit enter, and then ChatGPT will come back to you with a series of recommendations and treatment plans. But in all seriousness, watching the conversation is that the future of medical direction will advance with every aspect of technology and should never be limited. But we also understand, even at ODYSSEY, trying to implement something as simple as it sounds to implement an EPCR, so an electronic patient care record, is proving to be very, very difficult. It sounds simple. Put some shit in the cloud, give people a link, tell them to fill it out, and hit enter. But it actually is much more complicated, and we've been at that trying to find a solution for that for years. So I think the future of medical direction has a lot to do with the technologies. I think of Avin, who's out in the middle of nowhere, with limited access potentially to technology. And then, Aaron working in town where, Wi-Fi access to internet and all those things are readily available and consistent, right? So how do you make a system that is future-proof? And the answer is there's not one that fits all in that case. And the utilization of the new technologies, there'll be lots of technologies that are fad, but I think if you went back and told somebody Back to the Future kind of stuff, like, oh, in 20 years, we're going to have these things in our pocket that are going to be equivalent to, more computing power than we landed on the moon with, and we're going to have one-to-one communication. And, who remembers the Jetsons, right? There's a lot of us that look back and thought, oh, well, that's what we were supposed to be living in 2023. And in some ways we are, but in other ways we're not. And final point is that medicine is still a community that uses fax machines, right? So as much as all of the technology has advanced, medical direction, online medical direction, call control, ability to get 24-hour support, and absolutely blocking us in the fact that we still have to transmit stuff by fax machine, right? Because it's terminal to terminal. Carrie says ChatGPT. It is really interesting. I wrote a technology piece for a board of directors at Carrie. I asked them to write a use of technology for a volunteer board. So I typed that into ChatGPT, and it spat out a 2-page use of technology for a board of directors. So I put it into the meeting notes, and then the bottom in about 7-point font, I was like written care of ChatGPT. And so they all read it and they're like, oh my God, man, you put a lot of time into this. This is really well built. And I'm like, yeah, but look at the footnote. And they're all like, what? And it wrote it in 37 seconds. You know, it's incredible. Yes, it has limitations to generational gaps, but it's fascinating what technology can do for us. But I think too, is that medical direction as an online control model is not something that we do, you know, in the private sector. It feels like that's a very hard thing to understand, how you even conceptualize having somebody at the end of a phone, right? When you're flying Air Canada and you're coming across and you need to flock to the flight surgeon, well, they've got enough money to pay for somebody to answer the phone in that context of the services that are required and rendered for environments that are just not traditional. Thanks.
Yeah, totally. And actually, just going off of your comments, Kevin, and Carrie, your comment around chat GPT, I think that's actually going to be a real asset to future policy writing and best practice, because it can really help kind of collect some of those guidelines, as long as there's still that human element of actually vetting and making sure that it's accurate. And I'm sure everyone has seen some of the news around some of the false sources of information on chat GPT, but that could be a really useful tool, and actually kind of pulling together some of the resources and creating some of that structure based off of previous policies that have been written, and trying to help support best practice. Awesome. Well, thanks so much, everyone. This has been great to chat about this.